Thank you, everybody, for... Don't clap yet. Say that for the end. You may want to take that back. So first, before we start, I just got to acknowledge Dr. Frakes in the back here, Al. He was my auditing professor back in the day when I was at WSU, so I think he's come to critique or take my diploma back. I'm not sure. We'll see how this goes. So a little nervous now. Thank you. Tell you a little bit, just kind of horror story. So I'm really very young, Ruben, so the reason I got this job, I had to pay off my bill, and I'm still trying to pay that off. So I relate to everybody's questions regarding hospital billing. No, not really. But I did start the hospital back in 1988. It's hard to believe it's been that long. Great family to work with. I don't know if you or many know this. In 2002, I tried to escape. I resigned from Pullman Regional Hospital as a CFO and moved to Tucson, Arizona. I didn't get too far out of town before Scott asked if I could stay on and we'd work out some type of arrangement. So I still reside in Tucson. I've been doing that for 15 years, so half of my career has been living in Tucson and still working at Pullman Regional Hospital. Pullman Regional Hospital is dear to my heart. Have past board members in here tonight, and they all know. Once you get Pullman Regional into your system, it's hard to get it out. It becomes a part of you. You believe in the community. You believe a lot in what we're doing. I really appreciate that, and especially working with fine people like Mr. Adams and Mrs. Eiler, Dr. Caggiano, that have really become family members. Shauna Patrick, who's my controller here, has been with me. Shauna, we've been together 16, 17, 18. I mean, it's been a long time. And
20 years.
Yeah, it's amazing. You got great people. So let me start with a little bit. One of the nice things about doing it in this environment is I've always believed whenever I'm talking with anybody, you have to give them a takeaway. Either that or you're investing time here. And if I failed to do that, I failed. The nice thing is we're feeding you, so at least you get away full, hopefully. So at any point, if you want more, feel free to get up and go get more. And so at least there's one takeaway, so I feel good about that. But let's start with a little bit here. Little thing. So, little words of wisdom here. So being an accountant, the pessimistic side of me, that really rang true. But our goal tonight is talk a little bit about healthcare and specifically Healthcare Finance 101. In an hour, we got about an hour. So, and I'll hold pretty true to that. We'll get you out a little probably early, but really this is your time. If there's questions you have specifically, I will address those the best I can. If there's something I don't know, I will go find out and I will make sure that you all know by the within a few days. But hopefully, that you'll find this very meaningful in terms of a better understanding. So that's our goal. To do that, we have to have a baseline knowledge. We have to have a working platform to communicate effectively. Because healthcare, like any industry, we have acronyms, and I don't know if it's purposeful so nobody else can come in, it's like a club, or if it's actually the fact that we just try to simplify our lives by having acronyms. And we throw them out as if they're everyday speak. So let me talk about a little bit of things just to make sure as we're going through this, as I mentioned something, we're on a common ground, okay? So first thing, when we talk gross charges, this is what we bill the patient. Right? It isn't what we get paid. But any patient comes in, it's going to be whatever they had done times whatever quantity of whatever they did, and that's going to be what gets billed out. Okay. From there, we have contractuals or deductions from revenue. That consists of things like bad debt. We have patients that don't pay their bills, hard to believe, right? We also take care of the indigent, those that can't pay their bills. So we have charity care, ways by which that they can have services as part of our mission. And so they'll come in, and if they qualify, parts or all of their bill can be written off. And then in addition to that, we have contracts. Now we have a contract with the federal government, Medicare, Medicaid services, and they tell us what they're going to pay us. You don't get to negotiate that. Under that means you get told what you're going to get paid. However, other insurance companies like Primera, Blue Cross, now Group Health, Molina, any of those we negotiate contracts with. We never get 100%. Back when I started, we had contracts that were 98% of charges or 90% of charges, and today the best commercial contract we have is right around 73.5% of charges. And so things have changed significantly.
Is Medicare still 33, 34?
So the question, that was my sign to repeat the question. So is Medicare, Medicaid around 33, 34% charges? The write-off is around 45% of charges, 50%. We'll get into that a little bit of what that means and how that works and what specifically it means for Pullman Regional Hospital. So if you take that gross charge and you subtract those write-offs, be it bad debt, be it contractual, that's really the net revenue. That's what the hospital has to be able to fund, current expenses, which would be salaries, wages, benefits, and future things like capital, etc., that ends up being part of depreciation and the like. From there, once you minus all of those daily operational expenses out, that's what we have in terms of our basically operating income. Now I'll tell you, in healthcare, margins are small. In almost, especially critical access hospitals, most of them don't have an operating bottom line. The only way they have a positive bottom line, and many don't, is the fact through non-operating means. In our particular case, we have a great community that supports us. We're a public hospital district, and we get tax support, which has been tremendous blessing to us. In addition to that, we have some properties in which we rent. We get some rental income off of. That's a non-operating. That's not what we're in the business of doing. And then other things are like foundation donations, which are very beneficial to us in order to be able to provide the spectrum and the overall care that we're able to do here that many communities can't do. So a lot of it is the support we've had from the community itself. So that ends up being the net income. In our business, it's almost, you can't have a profit. We're a nonprofit, so you can't have profits, but we have excess. We have excess of revenue over expenses. What does that mean? It's bottom line. You call it bottom line, call it net income, call it anything you want. It's really your profit. Now I'll tell you a story just for a second. I'll just digress for a minute. And Al will probably appreciate this. My wife's a pharmacist, and she's probably, in terms of knowledge and brightness, she outshines me by far. But she had to take her senior year, she had to take an online course or one of those that just to fill a GUR. I said, "Oh, take accounting. It'll be simple. I'll teach you. I'll help you." I thought we were going to get divorced our first year of marriage because she couldn't understand, well, what's this net income or profit or excess? Why can't you just call it the same thing? Well, it is. It just depends, what business line you're in. Owner's equity is the same as the net worth is the same as, et cetera, and she just couldn't get it. And I finally just said, "Oh, okay, I think somebody else has to help you." But we got through it. We're still married. It's been 30 years, so somehow we made it through that. But a lot of these terms are interchangeable, and we'll talk about some of those, so I'll throw those out. Here's your first opportunity to have a quiz. She said I can't ask her questions, but no, this is for the whole room. Let me ask you a question. This is your first test. These are reimbursement theories. These are different reimbursement methodologies in healthcare. One is diagnosis-related groups, DRGs. Folks may remember those came back in the early 80s. Medicare came out with that and said, okay, we're going to say every patient that has a X diagnosis of this will be in this grouping and we're going to pay Y. So they created this in order to control their costs. MSDRGs is another methodologies. Anybody know what that means? What's the difference between a DRG and an MSDRG? So there's certain things Medicare don't typically pay for. Pregnancies. Not very many people in the Medicare population are pregnant, etc. So commercial payers have additional DRGs listed, which are the MS side of it, medical surgical side. Common procedural terminology, CPTs. Full charges or percent of charges. and also cost. So let me ask the question. Which of these does Pullman Regional Hospital get paid under? Go ahead, Mayor.
All.
Thank you. Good answer. Every single one of those. Not confusing whatsoever. We just got to figure out which one and play the game right. And by the way, insurance companies love to change what's acceptable and non-acceptable, what's allowable and non-allowable. We'll get in a little of that. But we get paid under every single one of those. So it's really dependent on the payer. If we had 100% Medicare, it's so much easier to budget. We don't. We have a variety of various insurance. Today, our population, in terms of Medicare, Medicaid, runs about 45% of our charges. Pullman's in a very good position from the terms of the ability to do what we do because we have a very good payer mix due to the fact that we have Washington State University here and SEL here. Not very many communities of our size in rural America have that luxury. Most of them typically, you can think of small farming communities. There's a lot of Medicare, Medicaid especially. You think of Othello, think how heavily Medicaid their population is. It's hard to make anything. We'll go into why that is in a minute. So we're going to lay, again, we're still laying some framework about Hospital Finance 101 because some of this is meaningful in how you approach services you may provide. Hospital structures, these are really the three types of structures. Public, which would be federal, state, local, ran facilities, non-for-profits, and for-profits. In our geographical area, how many of these do you think we have? Think of the Quad Cities here. So we know we have, you may not, we have 2 public hospital districts in this area. In fact, there are 3 public hospital districts in this area. You have Pullman Regional Hospital, we're a public hospital district. Number 1A of Whitman County, doing business as Pullman Regional Hospital. And then you have public hospital district number 3. Anybody name who that is? Whitman. Can anybody name the other public hospital district? Garfield. Do you know the hospital in Garfield? No, they do run assisted living and home health, but that's their district. They used to. Years and years ago, there was a hospital, but they don't have one now. So those are your public hospitals. What about non-for-profits in our region? Think of any? You got Gritman. Down the valley, you have Tri-State. Today, you have a for-profit in our backyard that you never had before this last year. St. Joe's. That will be a new dynamic.
Steve, does Garfield include the EMS system?
It very well could. So does Garfield's hospital district include the EMS? Likely to support that. I'm not clear on that, but likely. They do have some tax bonds. So in our population, you can see this is a distribution of this across the United States. Many are not-for-profit, as you can imagine, supported in one way or another. Not very many for-profits. In fact, CHS, which is Community Health Systems, is one of them. Almost all of them run out of Tennessee for some reason. I don't know if it's a tax advantage or that's where they all. RHSC, which actually runs Tri-State, is another one of them. But many of them are divesting, so if they aren't making money, they get out. And I'll tell you right now, for-profits typically run margins or working towards margins in the double digits. Non-for-profits are typically around 1% to 2% across the United States. And we're really no different than that. You'll have a few that are higher than that, but not very many. You can see how many are in urban settings versus rural settings. So, not a complicated system at all. It's pretty simple. This is one segment of that. Remember under payment methodologies we just talked about? This is one aspect, and this is just the Affordable Care Act, by the way. And by the way, you're here. This is you. So to get paid, this is really pretty simple. You just got to work through all of these means. A lot of regulatory issues and things. So when people wonder why healthcare is a challenge in terms of reimbursement and making profit, there is so much. One of the highest regulated bodies in the United States is hospitals. This is just to get payment under this new healthcare system. So there's no additional taxes and wasted within this at all. It's pretty seamless. And this is changing all the time, so you got to learn, how to play for it. This Down here, which is the Medicare, Medicaid services, it's changed significantly, especially under physicians, if you recall, and how they got paid just changed this last year. And they are going to now, their increases, which was budgeted and under the SQR, which was the growth, that's how they got additions every year. Now they've changed that, and it's called MACRA, and the way physicians will see increases, there'll be no new money, there'll be winners and losers. And it's all based on quality and what your reporting scores are. And if you do it right, then your neighbor doesn't do it right, he loses money and you get some of his money, because it's budget neutral. And that's the payment increases that physicians will see moving forward. How many physicians like to be under that model? Not many. How many people have felt or struggle even here on a local level to find a primary care physician? A few. It's been a challenge. We have people retiring, and it's hard to recruit. Pullman's very attractive from a destination, but you can imagine some of these rural communities where it is really a struggle, and we struggle. In fact, we were down to, in some of our primary care practices, and this is just, I say our, because it's a community-wide thing, half the providers they used to have 4 years ago. And they're trying to recruit in. It's challenging in the market, because why would you want to do that, especially under the old payment models? We're going to talk a little bit about that. The revenue cycle. So as you think about Healthcare Finance 101, how we make our money is through seeing volume today. There will be a point in time, I think years from now, in which the less you see, the more you make, because it'll be value-based. You want to keep people healthy, which should be really our mission. Today, we keep people healthy. That's not good for our bottom line, but it's the right thing to do, and we're doing those things today. We have a whole care coordination team over here with social workers, and we don't get paid a dime for that, but it's the right thing to do for our community. If I was strictly a for-profit, you know what? They wouldn't have that. Your Red Sage would be open from 10 to 2. It wouldn't be open 7 to 7. Because I would be cutting every cost I could out of this organization and putting every dollar I could to my stockholders. There would be things I wouldn't run. I would not run 7.2 physicians in my emergency department not 24/7, I don't have that many physicians, but round the clock. I'd run at bare bones, 4.5 FTEs, run them till the bone, and hire another one coming in to 2 years, burn them out, get another. Because I could save hundreds of thousands of dollars. But the quality of care wouldn't be there. And you just burn through people. It's not that their quality's bad, because they still score very well. It's the fact that the experience is much different. I speak from a personal level on many of this. My wife works for CHS as a pharmacist, and I will tell you, it has been a struggle. They opened a brand new facility in 2004, December. Sound familiar? We opened ours in December. They have been burnt through 15 pharmacists. They have 3 at any one time, and they've burned through 15 pharmacists since she started to today. We've had 1 retire. Tells you a little difference of the culture, because it's not about the people, it's about the bottom line. So when you think about revenue cycle, you think 0 to 0. You'll all be experts. I mean, you can start consulting businesses after tonight, because not very many people really understand this. 0 to 0. How much do you owe when you come in into registration, or you come in for a lab? Before you have that done, how much do you owe the hospital? Nothing. You come in, you have that service, when you have that surgery, whatever, you go through a process. You hit registration. Within that registration process, there's things that should have happened either before or happened during. With authorization, does your insurance authorize you to do this? Did you have to have a referral? If you didn't have to have a referral, I'm sorry, you'll have to go back to your primary care, get the referral, then when you can come back, we'll have the procedure after that. If not, and they didn't require a referral, or we had the referral, then we have to have authorization, because if we don't have authorization, they won't pay us. And if we miss that step, guess what? We're out. Or we fight insurance companies. We write a few letters. I'll tell you, this year is much better than before. We've had 64 denied claims. Last year at this time, we had 250 denied claims. Jumping through insurance companies' hoops on trying to get paid. That's this process: registration, insurance verification, point of service collection. We don't do a ton of that here because our people are very good here in Pullman about paying for their services. Some places they'll require you to almost pay your deductible up front before they'll ever treat you. Financial clearance all the way through till the very back end of it. After we do all of the billing process, insurance pays, we go out, we collect the deductible, we write off the contractual write-off, that account goes to zero, zero to zero. That's the revenue cycle. All of those things have to flow very fluidly in order to get there. Sometimes they work seamlessly. We can get paid 14 days and be done. On average, the hospital, Pullman Regional Hospital, takes 34 days to collect zero to zero. How does that compare across the nation? Across the nation, it's gotten much better. It used to be around 50 days. Now it's about 48 days across the nation. We do very well here. We got good payers. And some of them, you can get this whole process done within a couple weeks. Sometimes it's not that easy. We still have accounts that we're working on that are almost a year old. Got denied. We appealed the denial because they didn't tell us. They changed the rule on what had to be authorized beforehand. We had the physician write that this isn't appropriate. They are in review. They deny it. We go back through it. We fight it. We finally get it paid. Or a patient comes in and they say, I have Primera. Give you the card. Come to find out, oh shoot, no I don't. We changed. But you don't get that until you get the denial from the insurance company. You go back through and they go, no, I have. And then they give you a different card and you go through that process and it takes time. So this is just how this segment would work from 0 to 0. You schedule, you come in, you check eligibility, you treat, you code. The coding aspect, that's your medical records once it gets coded. And by the way, do this right. So one thing, let's say you had a total hip. If the physician didn't write that he put the device in and didn't chart that he put the device in, but you were walking around evident that you really had a total hip, we don't get paid because it wasn't documented. So if you didn't document it, it doesn't matter if you did it or not, you didn't do it. So you got to document for everything you do. So a lot of this is making sure we educate, train, and then you go through the whole collection process, which is active collections, insurance billing, post-collection, which if somebody didn't pay, how do you collect that? All the way to legal, where you might do liens. Many times, hopefully it goes very clearly, but sometimes it doesn't work as well. So this is just another aspect of that. This is one bill. 50% of everything we do is going to be done on the front end. And most hospitals in the past haven't treated their registration staff as a key player. 50% of getting this right happens there. If you don't train those people and you don't keep good people, you got a 50-50 chance of ever getting paid. We do a very good job, much better. 2015, we wrote off almost $2.some million in process errors and things because front end was bad. Now, much of that we denied. We got denials and stuff. We had to fight to get every penny of it, and we do very well at that. But if we fix it on the front end, we don't have to fight it on the back end. And that's so we did a tremendous amount of effort to clean this up on the front end, and today it's basically gone. 15% is in the actual medical records, so the coding aspect of this. This is when it goes through our coders, inpatient, outpatient. They read the documents, what was documented, what should that CPT be, making sure they code all of that out, that DRG. That's their job. If they do very well at that, we get paid well. And then 15% is on the charge entry. Now charges. So this happens here. I've talked to nurses, I've talked to staff many times saying, don't make the decision on what should be charged to the patient or not. Document effectively so that we can bill appropriately. Because if you document what we did, then we can bill. If somebody can't pay, I have all kinds of ways to be able to help them. Charity care, payment terms, let's pay it over 12 months, etc. Those types of things I can help patients with. But if the nurse up front decides, poor college student, they're probably only eating top ramen, let's not bill them, I won't charge them for that, they don't look like they should be, then I have to raise charges somewhere else to cover that. That's a loss leader. So we aren't pricing effectively for everybody else. So we have means by which to handle that, so let's just bill appropriately. So that's part of that charge entry side, that's what they do. And then the billing aspect, which is your financial services component to it. So a little bit about Pullman Regional Hospital, get a little more specific. Those were some high-level aspects of it. We're going to drill down a little more about who we are, what we do, and how it works. So today, most people know Pullman Regional Hospital, right? But I don't know if very many people know or how many people know we have Pullman Regional Hospital Clinic Network. We own today 3 clinic practices directly, which are wholly owned, means Pullman Regional Hospital is 100% owner. They're as an LLC, but really they're 100% owned by the hospital. That includes Pullman, Palouse Pediatrics, Palouse Psychology and Behavioral Health, and today, Pullman Family Medicine, who just joined that clinic network as of April 1st. So we go back and we talk just a little bit as to why we might get into some of these. Oh, in addition to this, we have joint ventures with really 3 groups today. One is Palouse Surgeons. The others under Palouse Specialties, which is Palouse ENT and Palouse Urology. Those are owned 40% by Pullman, 40% by Gritman, and 20% by Whitman. 3 hospitals came together. Why do we do that? That's craziness. Let them do it. Let them sink or swim. You're on your own. Dr. Caggiano, would we have an emergency department if we had no general surgeons here?
It wouldn't be a full emergency setting.
You couldn't even offer an emergency department without having a general surgeon. You could offer an urgent care, but by rule and regulations, you couldn't offer an emergency department. You wouldn't be a hospital without them. Well, we had that situation facing us. We had 1 general surgeon on the Palouse running 365 days or doing 3 hospitals who said enough. The hospitals didn't jump in, we wouldn't have had anybody. And we said, okay, what do you need? I will only take call 1 week every 4. All right, we got to have 3 other general surgeons. That's the standard. So the 3 hospitals came together and we have 4 general surgeons today. Do they make enough money within their practice to pay for themselves? No. Because really, for this community, you probably need 3, 3.5, but it's hard to get a half a doc. They usually come in holes for some reason. I don't want a half a case. But no, they come in holes. And so there's a subsidy, there's a support, but the services they provide in the hospital offset that. That's not always true within primary care. But without primary care, we wouldn't have a hospital again because they had so many additional tests that they order. But under that model, if we go back and look and how many people want to be under that payment models that they were, physicians especially, physicians coming out of training today, they want to take care of patients. They don't want to run their own business. They want out of the insurance world. Who would want to do that anyway? It's a pain. They want to come in, and by the way, if they come into Pullman and under our model, no, you have to be a partner. And by the way, your pay is going to go down 25% next year compared to this year. Oh, where do I sign up? That sounds really good to me. I have no security for me and my family. It's not going to happen. When you can go to Spokane and have an income guarantee that's out of the gate 30, 40% higher, and you know you're going to get paid that every year, plus probably a raise, you wouldn't come. That's part of the challenges Pullman's facing with recruitment. So today, that's why physicians coming out of school, they want an employment model. And we have met that. We have adjusted our practices to meet those things. Because access to care is really important on the Palouse. So we have here about almost 450 employees, of which 274 are full-time, 174 are part-time. We have a great volunteer and auxiliary team that helps support our services at Pullman. Some are here tonight, and I really appreciate that. And then we have a very active medical staff. And the nice thing is we've been fairly successful on recruiting, which is good. It continues to be the case. So I'm happy to say that folks haven't heard, we have successfully recruited our 4th orthopedic surgeon to the Palouse, who will be joining the Inland Orthopedic Group. That's awesome. Those guys will be thrilled because that will make their quality of life that much better. On an annual basis, if you go back to our knowledge base, we gross billed. This is one we collected. I'd love it if we did. My life would be so much easier for me. But we billed out almost $117 million. Pullman Regional Hospital isn't a small business. We're a pretty substantial footprint. Of that, do you know how much we have at the end of the day last year to work with? To pay future bills like new equipment, technology? $1 million. Not a very high margin in healthcare. Not a lot to work with. And that is after we had donations from the foundations, et cetera. But those are the things that are really, we've got to then reinvest in the future. And that's the way to do it, is by having some type of bottom line.
Steve, with the robotics,
Mm-hmm.
I don't remember how much that cost, but we wouldn't have been able to do urology in Louis if we hadn't invested. And there's your problem, there's your $1 million. Very nice.
Yeah. So the question was, and the comment was, in terms of robotics, and many may or may not know, we have a Da Vinci surgically assisted device in our OR. Used primarily for single site incisions, laparoscopic procedures, when the recovery is so much better because you don't have the open incision and you don't have all of the after recovery time. It's pretty seamless. That's probably the wrong word for an accountant, but it seemed to fit. So it is seamless. It's pretty much a stitch and they're done. But it's amazing what they can do within that. That machine alone was over $1 million. And we had a lot of people in the community saying, man, why would you buy such a thing? We were successful, and the main reason to do it wasn't because we'd have an edge in a market and drive a lot of business, was recruitment. Folks coming out of urology school today are trained on a Da Vinci. Are they going to come to a market that has none, and that's the only thing they've known? No. So we were successful in that, and Dr. Kaiser has a partner now, Dr. Smith. And that was a great value. Dr. Smith, by the way, the two of them combined today are doing twice the volume. The volume was there. We didn't get it all. So Moscow also valued from that, but the whole community valued from that. And so it was really important as a part of our services that we offer. So in terms of, we're going to switch gears a little bit here, and that's a lot of this. If you want more, come to board meetings, Stefan. It's a ever-evolving thing, and it'll be different next year. This presentation would be different than it is this year because it's changing every day. But how does Pullman Regional Hospital develop its prices? Because that's an important question. Do we price higher than our competitors? Do we price differently than our competitors? How do we do it? I will tell you, when I first took over in 1995, I struggled with how hospitals, especially the ones I was involved with, because I came out of trying to combine Pullman Regional and Gritman Medical Center and ran the corridor for 3 years in a joint venture. I was assistant CFO. And Gritman did exactly the same way we did it. And what you do, and what we did, ashamed of it back then, is you developed a new service, you went out and figured out what the pricing was on many of those. Let's say it's X-ray and you wanted to do MRs. What's the average price? What are other people charging for this service? That's how you develop your prices. What is CMS going to pay us? Well, if CMS pays this, then you 2 times that. And it's just a rule of thumb. That's what you do. And then every year you go, in the budget, I think I'll raise it. Yeah, 5% sounds good. And you do that for 20 years, and what do your prices reflect? Nothing. They're meaningless. So we said that's not what we want to do in our pricing, and we want to be fair and adequate. So we go through a structure in which we evaluate what are our costs. Because we got to cover our costs. If we don't cover our costs, we aren't here, right? Pretty obvious. What's our required profit? Oh, nasty word. That's a 4-letter word. It's actually more than 4, 6. No, 5. No, it is 6. I can count. It's a 6-letter word. Profit. We got to have excess, right? Because we need to reinvest back into the facility. We have to buy equipment. We need technology. If not, you're going to be obsolete in a little while. And then really, your prices only matter. If I was 100% Medicare, heck, I'll charge you nothing. Because I get paid cost under a Medicare program. Doesn't matter what I cost. Doesn't matter what I charge, because they're going to tell me what they're going to pay, so why does it matter anyway? But that's not true across the board. It does matter. So prices have to reflect your payer mix. What are the insurance companies? We go through that process, and then we evaluate on every single price down to the CPT level, which is by procedure. What's our cost compared to the market? What's the market? If our costs are too high, is it fair for me to raise my prices 5%? Probably not. I should probably control the cost, right? If my costs are within reason, then is it okay to raise 5%? Well, maybe. But if I have $45 million in the bank or $150 million and I want to charge 10% more, because as a CFO, I'd like to have $180 million. That's probably not fair either because I have too much cushion. Now I'm gouging. So we look at that as well. So we want to be fair and equitable. And I don't want to charge more than the market. And in our market, we look at 6 hospitals. We have to do a blended because it would be collusion if I was to call Tri-State and say, what do you charge? You know, that wouldn't be right. I'd go to jail, and I don't look good in orange. So we do a compilation of 6 hospitals, and we have an external group do this. And we say, what is the price on an average in the market? Now, in some areas, I will tell you specifically in MR, we were too high 2 years ago. I had the orthopods call me and say, you know, they're getting a lot cheaper, and people are starting to shop because of the fact of high deductible plans where they have $1,500 out of pocket. They're shopping. We need to look at our market a little tighter than broader. When you pull Spokane hospitals and Tri-City hospitals in, that's probably too broad. So we narrowed that market and said, what should we charge for that service? And that's how we establish our prices. So now getting into just reimbursement and how we get paid. Medicare, Medicaid, people remember in 1997, the Clinton administration balanced the budget. And as a result of that, there were 2 hospitals in rural communities closing every week and people not having access to care anymore. It's a bad thing. So they came out with this determination called critical access hospitals. It is critical for our weakest population in terms of Medicaid, people that can't pay, and our elders to be able to access care in these communities. We need to do something about it because we're not paying, the federal government, not paying them enough to stay in existence. Basically, they're not covering their cost. There's not enough volume, and they can't survive. So that came out. So Medicare pays us today our cost plus 1%. Now I'll tell you what, it's not plus 1 because we still have, remember a few years ago, sequestration, everybody thought that went away. It's still not. We get cost minus 1, so we lose money on every Medicare, Medicaid patient. Doesn't mean we shouldn't take care of them. We should care for them. But we will never make more. Oh, by the way, I forgot to tell you something. It's not truly cost. It's allowable cost. You know who determines allowable? The federal government. So you know those same physicians I told you about in the emergency department? Because physicians can bill a professional fee. In addition, we bill the technical fee, which is the nursing staff and the room board. The way Medicare looks at it, then that professional fee covers that physician cost. If there are additional costs, like you want them 24/7, but there's not a patient there, that's your problem. That's not our cost. So that's non-allowable. So it's not 100% of your cost. It's what Medicare says will be 100% of your cost. And then our commercial players have to make up the difference. This is the rub. This is where commercials are fighting back. Because we have employers that are saying, wait, I can't have double-digit increases year in and year out on our premiums. We say the same thing. We provide health care and we don't like it either when our insurance for our employees goes up by 10 or 12%. So we start going, okay, how do we do it differently? But we're paying ourselves. So I was like, well, geez, can we do this differently? So commercials have really pushed back on what they used to pay. That's why I don't get 95% of charges anymore, and now I get 73.5% of charges by some contracts, because they're trying to drive that price down.
Are those 2 costs the same?
So are those 2 costs the same?
Yeah.
Yes,
On the left and right of that diagram?
they are. So it's your total cost to provide that service.
Is that a variable cost of providing that service as opposed to, is there overhead allocated?
Let's go there. Let's talk about that. So we're gonna get there. So yes, and yes, it is a variable, but understand in our who we are, from we being a rural hospital, it's semi-variable. At only a certain level can you go down before you hit a floor. We have to, by a certain amount, if we're going to offer 24/7 emergency care, I can't have nobody in there when you show up. Somebody has to be there with the lights on to care for you. That's the floor. So it's a semi-variable. So there is some fluctuations in those costs based on volume. But it's really hard, and I'll share a little bit about Pullman's approach to that on how you control those variable costs. I will tell you from a productivity standpoint, what's the number one expense you have in healthcare? What's your highest cost? People. We're a service industry. 60% of our costs relate to people. What's the number one thing that you try to control? People. Because, I can cut a lot at trying to chisel down utilities, but I can't turn off enough lights if I was one staff member less, to cover that cost of turning off all the lights every day when somebody walked out of the room. So there is some variability. Now, one of the challenges there is how predictable are our services? Can anybody tell me how many people are going to come into the emergency department between 7 tonight and 9 tonight? Is there a football game? Probably higher predictability that I'm going to have more admissions in my emergency department than I have when...
And more ambulance runs from the city.
Exactly.
And the police department.
You can have some of that, but it's still variable. And it doesn't always come. When we had the Apple Cup here, we staffed a whole unit just in case, because the year before we were inundated and we didn't have that many. That's the challenge we run. We can run on an inpatient unit, med-surg unit, 2 inpatients to 12 inpatients. And that can be a difference in hours, and it can be a difference in days. So we have 25 beds across the board, OB, ICU, and med-surg, and we can have an average, we can have census from 2 to 25. And that can be within the week. And then back to 5, and then to 10, and it's really hard to get that predictability. How do some hospitals deal with that? I'll tell you, a lot of your for-profits, etc., will say, okay, staff, I hired you full-time. You have a family and kids. That's all right. Come on in. Well, we're going to pay you full-time. I'm sorry, I don't have enough patients today. Go home. Without pay. I do that to you 3 or 4 times this month. Guess what? You're going to the hospital down the street that doesn't do that to you. We don't low census, and a lot of it's low census, and we don't do a lot of that here because your actual turnover rate increases significantly. It's better to retain those employees than it is to be training new employees all the time. That's part of the challenges we have here, and that's why Medicare decided, we'll pay you at least your cost, because when you have enough volume, you can cover those loss leaders every now and then because you have enough volume, and your variability is a lot greater. Here it's not, so that's why Medicare came in and said, we'll pay you your costs. Problem with that is there's no incentive to control your costs. I'll give you an example. A lot of our total hips, total joints are Medicare population. No surprise, right? Have you had one? Yeah. 2. All right. So.
Did you get your money's worth? Yeah.
Of course. Does it help Pullman Regional Hospital to negotiate with Smith & Nephew and Depew on those devices and save money? Does it help our bottom line for especially the Medicare population? Thank you. Not one bit. I get paid my cost. Where's my incentive to control the cost? However, we did go, and we do. I negotiated with Depew and Smith & Nephews a year and a half ago. We saved $1.2 million in our device costs. Most of that goes to the federal government. It's the right thing to do, because that will save, eventually, if every hospital worked hard at doing those things, that saves critical access hospitals the chopping block. If I lost critical access hospital reimbursement today, remember that $1 million I told you we had last year? Take $5 million off of that. We would have lost $4 million. We wouldn't last. You would be amputating major services. There'd just be things you would not do in this market. It just would not be there. No ICU. You wouldn't have a hospital around this area that had an ICU. Behavioral health, forget it. Those people are on their own. Good luck on managing your drugs and your problems. because you can afford it. Positive margin areas. These are where we make money, especially on a commercial side. Imaging, surgery, pharmacy, women's health, lab, pathology. And we don't actually have a pathologist that is part of the hospital. They're actually a group out of Spokane that reside here. But those are your money makers today. Your negative things, medical groups, physician practices. Oftentimes, for every employed physician across the nation in primary care costs $110,000. That's net. That's the bottom line. That's the loss you cover. Pretty close to that. Not quite. I'm pretty close. Transitional care units, your home health, your ICUs, your emergency department. There's so much fixed cost in those. Now, my physicians would say they make money, but they do in essence because they order tests. People end up going to the surgery. It's important to have all of them. You can't have one without the other. So how much did that cost? You go to a store and you look and say, okay, what's that TV going to cost me? You can see exactly what you want. No one patient that comes through the emergency department with the same thing is exactly the same. You come in, I do your hip. Your hip isn't the same as your hip. Your hip. How long it takes that surgeon because you had a complication within there can be significantly different than the person that had no complication. The resources and intensity of services are much different. Some areas you're going to get paid more because that DRG will reflect that, but not always, because the way Medicare pays you, they pay you off a DRG. Now, there are two different DRGs, one with complications, one without. But you might have been in the same surgery without a complication, but you might have been in the OR because when that surgeon was in there, it took a lot more time. It took him 45 minutes, where the other patient took 20 minutes. The resources are much different, but the amount that we're going to get paid is the same for that particular insurance. But if you go back to those methodologies, remember those cost, fixed, percent of charges, DRG, MSDRG, those all have influences within this. So those are all different depending on the thing. Hey, we're just talking about you, by the way. We're talking about orthopedic surgeries. No, not you specifically, just chalk prices. Welcome, by the way. So again, some reimbursement methodologies, and we've talked about under the hospital. You have percent of charges, you have per diems, case rates, a mix of the DRG, MSDRG components to it. APGs, which is an outpatient payment scheme, we have none of those here. They do have them, and they are significant across the nation. We're just fortunate. Some insurance companies want me to go to there. Primera wants us to go to that. However, in order to do that, the system behind that to capture all that would cost us $50,000, so I asked Premier to pay for that. They didn't want to, so they keep paying me percent of charges. But there's a big investment. We're moving towards VBS, which is value-based purchasing. Bundled, anybody heard of bundled payments, especially the joint replacement program that CMS has done across the nation? That's a movement. What that's doing is saying, we're gonna give you this pot of money between your physician, hospital, nursing home, and everything else in between, PT, et cetera. You divvy it out. You've got to deal with only that component of it. Problem with that is if you're not on the same team, you got winners and losers. So I'll tell you right now, under a bundle payment, we're going to work really closely with physicians. I'm sorry, nursing home, you're out, because I don't want that patient in the nursing home, because then I have to give them some of that money. So we're going to try to do everything we can to keep them within this little group. That's why you need to work collectively together, because it usually there's winners and losers in those things. But that's where it's moving. These value-based things are evolving significantly. Eventually, a lot of our payments will be based on keeping people out of the system, which ultimately should be what we're doing. That's in the business we're on, is taking care of those in need and trying to keep people healthy. But you can't make people be healthy. So these are the basic overviews, and we've talked a little bit about that within that. So you've got, for us, we're critical access hospitals. Other systems outside of that, PPS hospital, progressive payment systems, those are your typical urban. They're going to get this DRG fixed rate. And the more they see, then the more they're going to make, because they can cover their overhead. Critical access hospitals were not able to do that, so that's why they came up with this methodology. All right. Now, I covered that. We will move on from that. I probably covered that. All right. So hospitals converted to these CAWs since cost reimbursement was and is greater than the reimbursement we would have received under PPS. So that's why it was important to move to this. There's requirements to say that. Back under Obama, he had within his proposed budget plan, you couldn't be a critical access hospital within 10 miles of another facility, or you would lose your critical access designation. Do you know how far we are from Gritman? 9.2 miles. Why didn't we build it just up the hill another? But the issue was, who cares if it's 10? Why not 15? Why was it 10? Because it was a budgetary number. They looked to see how much could they capture. Oh, that helps our budget. Fortunately enough, Congress did not pass that. They didn't even entertain that. We only had to go a few times to DC to fight that. But that was the discussion. What's the mileage? You know what I would have done, Mayor? Come to you and say, please close down Bishop Boulevard. Make us go around. That's no longer a, let us go half a mile. Yeah, exactly, something. We just need a 0.8 of a mile, please. Figure something out. So, Al, part of your question, cost typically in hospital. Variable cost includes your supply, your implants, your staffing, your food, your dietary, your pharmacy. Fixed costs, CEO, core staffing, utilities, your debt service, and then your physician compensation, because many of them have a fixed payment. Not all of them. Some are very productivity based, and so the more you see, the more you make. But that's changing in their environment. So really, some of these really truly are semi-variable. There's only a certain level that we can go down to. So this is supposed to be a true and false. I'm just going to give you the answers here. Generally, and many are not sensitive to volume. If we saw 15,000 emergency department visits or 5,000 emergency department visits, I'm sure hoping the hospital still keeps one CFO. That's tongue-in-cheek. So I'm hopefully not volume dependent. But at some point, like even our human resources, at some point we need additional support. When we have, like a few years ago, we had 300 employees, now we have 450. The amount of paperwork and processing of payroll, et cetera, is more intensive. So we either have to find system applications to do that, technology, or we add resources and staffing to be able to help support those. So, cause, volume increase. What happens to your fixed cost per unit of service? So volume goes up, and I have a fixed cost, me. Let's say we have 100 patients, and we allocate the cost of administrator over those 100 patients. Now I have 200, what happens to that cost per unit? It goes down. Same thing, if we have 200 and it goes down 100, that cost per unit goes up. Same with variable cost. Units of service equals patient days for room and board, revenue and charges for ancillary services, okay? Reimbursement under PPS hospitals. You decrease your volume, what happens to your reimbursement? It goes down. The less you see, the less you make, right? That's traditional. We all know that. You go to Walmart. They sell 1,000 TVs. They sold 1,000 TVs. They sell 2,000. They made more, right? The more they sell, the more they make. Guess what? Critical access hospitals, that's counterintuitive. It's not true. If I see less patients, what's my reimbursement from Medicare going to be? It's higher. Gotcha. Why? Because they pay me my cost. My cost per unit went up. So the less I see, the more I make. The more I see, the less I make, because I'm only ever going to get paid my cost. It's counterintuitive. And so that's always confusing. It doesn't matter if you're sitting on the board or not. Yes, sir.
But doesn't Medicare define what they have observation beds, which you get paid less for, versus a regular bed. So they're defining your cost is going to be that observation bed, because that's all I want to reimburse you. Aren't they doing those kind of things still?
So the question really is under Medicare reimbursement, how do they define how they'll pay you? Do they drive business? I'm counterphrasing this.
They're
Do
also
they
driving to nursing homes too.
Right.
They're cheaper over there than they are at regular hospitals.
Right. So are they driving businesses to certain things like observation, like inpatient care? Is it better to have a Medicare patient in an inpatient bed or an OBS bed? OBS, observation, sorry, abbreviation. Which one's better? For Medicare, honestly, having them in an observation bed is better, because then Medicare constituents or customers have to pay 20% of that charge. If they're in an inpatient bed, they have a straight deductible and it's done. And if they met that earlier, it's done. So the Medicare population has to pay for that 20%. So having them in an outpatient setting makes a lot more sense for Medicare. They have requirements. So now they have, it used to be based on certain criteria based driven. Now it's based on how many midnights you're in. Are you in 2? If you're in 2, then you're in OBS. If you're in more than 2, then you're in N. It's based on that. So by the way, we asked for that, and we all hate it now. We said, we don't like the way you're doing this. You got to simplify, and then they simplified, and we didn't like it. So some of the things that are influencing healthcare and why it's getting challenging. We had a major change in our classification, ICD-10, which is your diagnosis related classifications. This changed from ICD-9 to 10 in 2014, actually in 15, and it really substantially changed the coding aspect, went from like 8,000 codes to 80,000. And so it's got a lot more specific. It's really hard to run today. To get any comparables is almost impossible, especially on inpatient care or surgeries and stuff, because of the fact that ICD-10 is so specific. Like they literally have some, if you hit by a car in a rural road, then you code it to this. But if you were hit by a dog, it's different. I mean, I could throw some up and you'd be like, really? That's a code? And they are that specific. It's really strange. Some of them are hilarious. I don't know how they came up with them, but they are. Like bit by a shark while scuba diving. Did they live? Inpatient quality reporting, the macro, which I talked about earlier on physician reporting, this is significant. You could have upwards of 9%. Now for physicians, that can be a huge swing in their pay in any 1 year. Yet, on the other side, if you do it well, you might gain. Readmission rates, we got to monitor that. All of these things are reporting requirements that we have to do. We don't get any additional money, but if you don't do them, then you make less money. So, one of the things in that, in summary, as we start to wrap this up, why does our foundation help us? There are many non-cost based programs. Psych and rehab don't make money. So by providing certain services and continue to support those across the continuum and have the foundation helping us within that so that we can be self-sustaining and self-determining in our future is really important. Skilled nursing facilities, SNFs, home health agencies, non-reimbursable cost centers. It's just certain things that we don't get any payment for, but we want to continue to provide those services because it's important to our community. That's where the foundation, that's where being a public hospital district really helps. Other things within cost reimbursements, hospital overhead that are non-cost services. Things like today, our care coordination I mentioned earlier. That's the right thing to do. Honestly, it costs us money to do it. We look to grants, and that's part of the foundation's efforts to bring in those type of things to help offset that. It doesn't dollar for dollar, but it's caring for patients and getting them in the right place so that their care is better, so that they don't end up in the emergency department with a major problem down the road. Those are really important things to do. Nobody's paying for that today. Some of the things the foundation has really helped us with in their annual giving, the whole Hydro Works pool therapy and underwater treadmill. We would not have had that. The system we had failed and would not be obsolete. It'd basically be probably a mosquito pond. It'd be gone. And that helped us tremendously. The 3D mammography unit that we have been blessed with happened in 2014. The 2015, various areas, a lot of different areas, services. In 2016, the OR project, and then now one of their major efforts is 2017 on the expansion. And as we look to that, it was why we needed that. In 2004, when we opened this, we thought we'd plenty of space forever, and now we're out of space. with volume have increasing as much as they have, as much as 25, 30%, we need more space. And that will be the case for a while. Then there's I probably got this out of order, but the surgery project, which is well underway and should be done by August, end of August, and coming online by September, which will be perfect. So, summary. Healthcare finances is complicated. I mean, we can't do it justice in an hour. I hope that you got a little bit of taste of the complexity and what it means within our institution on how we manage that. But each input is unique. Therefore, care delivery must be flexible. It can't be stagnant. Everybody, we're going to treat you the same. We'll put you on a conveyor belt. We'll run you through because you're all the same, and I can then control all of my costs that way. And we can't do that in healthcare. Physician orders drive. Physicians still drive everything we do. Without physicians in our community, we would not have a hospital. They still drive everything that the care today. So orders drive provisions of care, adding to the variability. Payment is also variable depending on who's the insurance payer. What coverage do you have? Does your insurance company cover that today, not tomorrow? By the way, one of those things that, we want an example of this, what do I mean? Premera decided, and I'll say this wrong, and please correct me those that know, but propofol, is that the right word? The administration of the drug, with anesthesia drug, especially colonoscopies. Dr. Jones likes that. It works very well. He wants the CRNA in the room.
Patients like it too.
Oh man, loved it. I had that done. It was awesome.
Yeah.
I remember nothing. But I got to tell you, when I came out of it, I had it done here because I didn't do it at home. And I had John O'Brien, my materials manager, come in and make sure I got to where I needed to go after we were done. And I told him, hey, call my wife, tell her I died. Because I thought it'd be funny. I don't remember actually saying that. I'm glad he didn't call her. But I thought it would be funny, I guess, apparently. But it's amazing probably what you tell people under that stuff. It was awesome. But Premera decided, we're not paying for that. It's an additional cost. Even though physician's preference is that, they're just not going to pay for it. So we help subsidize that for the CRNAs because it's really important to a physician for that aspect of care. That's what insurance companies do. So that insurance company is a big part of that. Negotiating those rates, payer mix, regulations have a big influence of how and what we do here. We're going through part of that. Within the next few months, we'll have a review by an outside agency that will come in and evaluate how we're doing. Are we meeting the Medicare standards? Technology changes rapidly. How do we reinvest in that? So we need a profit in order to reinvest, or the foundation has stepped in many gaps where we didn't have that to be able to offset that and help us continue to offer high quality technology and keep our prices reasonable. And then many different players in healthcare. All right. Yes, sir.
Is it truly a negotiated rate or is it a dictated rate?
Well,
Because what I hear from insurance companies, we're setting the standard here, where this is the limitation, and you may want to negotiate, but you're only going to be told how much you're going to get.
so the question is it a truly negotiated rate or are you just told? Medicare, Medicaid, they're the big boy, you're told. You don't negotiate. Other commercial payers, you do have the opportunity to negotiate. Your negotiating power is limited by, even within our community wall, by who's negotiating what. The more players, and as we talk about a fully integrated health systems where you have physicians and hospital and all that working collectively, you have more negotiating power. So then you do have the ability to go and say, at some point you got to prove outcomes. If you're proving this is what we're doing, and we're working on that, part of the Center of Excellence with the orthopedic surgeons is in developing that. At some point, we will develop a bundled payment that we can take to a Premera or to a Uniform and say, why would you want to send your patients to the west side to have this done? Have them done here. Here's our outcomes. By the way, our prices are half of what they are over there. So why wouldn't you want to have it done here? Keep them local. But if you can prove that, you've got to have statistics to do that. You've got better negotiating power.
And how long is that negotiation good for?
Typically 2 to 3 years. So right now I'm working on the Premera contract. Hospital loan, it's really hard because Gritman just signed last year, so I'm not going to get any better. than that. If I had an isolated market, I could. So I would take the same contract that Tri-State can get with Primera, but they have 1/8 the number of covered lives in their arena, so they can get 90+% of charges. They just don't have the same volume we do. Where here they can drive a lot of that. But it's getting more and more challenging. Have people heard of what narrow markets are? Okay, so we have one in our arena. It's the Catalyst Group. They went directly to the Blue Cross of Idaho, to a very isolated market, and they said, we'll take care of those patients. If that patient goes outside, and so these are self-purchased insurance plans, if that patient goes outside of the market, they have a $50,000 deductible. So they can go to Gritman, they can't come to Pullman, because that's how narrow they did the market. They kept it in Idaho. Those are happening.
A question for you on pricing, supply and demand. In theory, determines price. So how has the Pullman Hospital done in demand growth compared to population growth? How are we competing with the other guys?
How are we competing on supply and demand?
Right, are we increasing demand
Yes.
as fast or faster than population growth?
Not in all areas. So a lot of that is contingent on providers, and can you get a provider within those specialties? One of the things we're actively trying to recruit to, and we have been successful here just recently, is in non-invasive cardiology. The other area is in pulmonology and sleep. The demand's there. We have to outsource that today, so an outside group does all of that. All of those funds go outside of our market to be able to do that, because we may do the study here, but the providers aren't here. So there's no reinvestment back into the community for those like services. So in some areas, it's a real challenge because it's specific on that. In other areas, yeah, we're keeping up, and that's one of the reasons we're looking at building the 4th OR or adding same-day services expansion, is because the demand has been there. We are at capacity and we have just no more room in order to get that. Now, I say that almost tongue-in-cheek, because there's a lot to do with physician preferences, and if you're a physician, and Dr. Tingstead could speak to this, you don't want to start surgery at 6 at night unless it's an emergency. You prefer to get in and get out so you can get back to your clinic to care for your patients. And so most physicians have block schedules because then they can control their life. They don't want to just, oh, what do you have today? Oh, okay, we'll call and see if we can get them in today. That doesn't work very well in their life. So you have to have that capacity. But in order to do that, sometimes you have those downsides because nobody wants to start 2, 3, 4 in the afternoon. If we could run 24/7 in those areas and people willing to do it, you could control the cost much better. But you can't today because a lot of it's based off preference.
Medical errors you'd be dealing with.
You might, yeah.
If you're
Well,
working with a surgeon that long.
what you have in this market is, oh, well, I can go 9.2 miles and I can start at 7, so I'll take it there. Oh, no, wait, stop. We want them here. We don't want you to do that. So some of that predictability and stuff is very challenging in our market just based on providing health care. So I don't know if that totally answered it adequately or not. We can talk more if it didn't. No. Other questions?
You must have figures too. I know we have things.
I have a good figure.
Here
Oh, wait.
who's top of the game. But even a surgeon knows that they're only good for so many hours of solid surgery before, they get a little punch drunk too a little bit. So they know that you can commit a surgery unit for how long. Now, of course, that affects your pricing too.
Yeah. Well, yeah, and that's really dependent. You're exactly right. The quality of care of your providers, be it your nursing staff to your physicians, diminishes greatly if you don't give them enough rest time. And so one of the key importances of recruitment is to provide, especially physicians, break in between so they aren't on call all of the time, because you will burn them out in short order. Same goes for your nursing and support staff. If they don't have rest between shifts, and we used to do this, so you'd be done and you had to go late because a case went late, and you were on call and you got called back, and then you had to come back in at 7 in the morning to start it all over again. Quality goes down. Now what we do is we have a call shift. And then when they're not on call, then they're off. So they don't come in the next day. That's a different group. So you have to have staff, which adds some cost, but it provides a better quality of care. Plus rest between shifts. We guarantee a certain amount of rest between shift so that they aren't only getting 8, that they're getting 10, so they get a full night's sleep.
You're speaking staff, there's a difference in cost too, depending on if you have your own staff versus travelers. And we've had to rely on travelers here from time to time.
Yeah,
Not
occasionally.
as much as I saw over in Swedish in Seattle.
Yeah, 2.5 times the cost for traveler compared to what you can keep here. You're typically doing that in areas. Most of the time here in our market now, not when you were on the board, we had a problem back then of just, turnover because you were doing a lot of low census, et cetera. Today, if we have a traveler, it's generally due to somebody that's on maternity leave. It's a planned event. You know they're going to be out for 12 weeks. It makes sense. You're going to pay a little more, but you wouldn't want to hire because you made a commitment to employ them forever. So you do short-term stuff like that. We don't have nearly the travelers we used to. Yeah, it's typically that.
Steve, do you think the value-based system will survive if the Affordable Care Act went away? That was in the Affordable Care Act, meaningful use, et cetera.
So will the value-based payment system continue to exist if the Affordable Care Act changes? The Affordable Care Act will change. I mean, inevitably it'll change somehow. It doesn't matter what administration, it will change. I do. Healthcare, at the rate it was going, is non-sustainable. It has to change. You can't continue to have escalating payments and expect anybody to be willing to do and be able to pay for it. So it does have to change. How we deliver healthcare needs to change. We're reactionary, but America's done that to himself. We've done it to ourselves. We don't want anybody telling us what to do. We just want you to make it better when we didn't do it because that's a lot how we live. Fix me now. I didn't take care of myself, but fix me now. So some of that needs to change. That, getting in front of that and changing our culture and how we respond to that needs to change. So yeah, I do believe it in some sense it will. There's demonstrations that are showing how it will be. I don't know what it'll take, but today, part of the problem is the fragmentation in healthcare and the lack of communication between even us and our providers. And you think you're all on the same page, but you're really not in all sense. So streamlining that, integrating a lot of that will have a lot of impact on that. And I do believe that it will take such a foothold. It started out at 20% demonstration, and it'll expect in 2 years value-based purchasing will represent 80% of the payments in 2 years. They originally thought it would be 5, but that's how quickly it has broadcasted out. So it's here to stay, and we got to learn how to deal with it. The problem will be is we're under this payment model, which the more we do, the more we make. In some sense, I just contradicted something else I just said, but that's the healthcare system today, fee for service. Tomorrow, when we finally get there, I don't know what it'll look like, when it's value-based and you're providing value and you're keeping people healthy, how do you bridge that gap? That'll be the challenge. And hopefully you have enough to survive that period of time. And so it's really important. Now, we utilize, again, I'm promoting Ruben and his staff, but that's what we've determined as part of that pathway there to survive those time periods so that we aren't falling behind in technology and other things, so that when you get there, you can't provide it because you're too far behind the curve anyway.
When will it come that you're going to be dictated that I don't need to have another MRI just because I had one here for the specialist? And the insurance company is going to say, you already have one MRI for that particular injury. You don't need to have another one. Or they won't approve the second.
So the question
That's happening all the time. It's driving our home care costs.
So the question is, when will that happen? When will that occur? Meaning, will insurance companies dictate the fact that somebody else ordered a secondary test that has already been done? Is that fair? I'm doing this for her. She's told me I got to repeat these, so. I don't get paid tonight. No. I don't get paid anyway.
It's cost, don't worry.
It's cost. I get paid cost. So the question is when will that happen? It's happened. It happens today. Insurance companies, if you had an MRR, they aren't going to approve. That's part of that whole pre-authorization. If they see you had this test done, they're not approving one for another one. They'll deny it. So you won't get it. So that happens today.
You won't get
Now-
this one if it's workers' comp, for example. They've
Right.
already done that a few years back.
Exactly. So some of that's happening today. Now, is there duplication of services? Yes, that still happens in some sense, but more and more that's changing. So one of the things that is when you start looking at an integrated model and you start looking about coordination, it's when you're all on the same team. Well, you know, Dr. Joe is much better at this than I am. I'm going to send my patient there because I know that patient will come back, and we're not competing against each other. That'll be important to control costs. Because today we compete against each other for the same patient for many different services. All right, we have a few more minutes. Yeah, Pat.
Steve, what do you see as the overriding benefits of acquiring other medical practices? That's the first part of my
Yeah.
question. And the second part is, do you see us acquiring more in the future?
Okay, so the question is what are the advantages of acquiring other medical practices, be it physician practices or anything? And will we look to acquire more in the future? I will tell you this, Pullman Regional Hospital has not aggressively ever gone out and tried to buy any. We have reactionarily responded to requests. So, Palouse Pediatrics as an example, 2009, remember Al, Dr. Frostad, and Mike. When Al decided he was going to retire, Mike realized, I'm going to be basically the only pediatrician on the Palouse. I don't want it. And I don't want this headache. And by the way, I can make more money by being a locum and traveling and getting out of here and making a lot more money. So they realized that in order to have pediatric, which Al had established on the Palouse and continue to be here, they needed something different. They came to the hospital and said, would you be willing to look at this? And for the sake of the community, we responded and say, yeah, we'll look at that. So most of everything we've done has been in response to. So many providers today, when they look at the model of reimbursement and trying to recruit into it, are facing challenges and saying, people don't want to come to that model. They will come to the hospital and say, can we look at something different? We'll always look and say, what does that look like? So there's no future plans right now to continue, but we would respond, being the thing. Some have decided to stay independent. The advantages that we're starting to see that are coming. I talked about care coordination. I mentioned it a couple different times. There are new reimbursement models that will pay you a per member per month to do that. Most all that resides in primary care. We had no access because we had no primary care under our clinic network provider that to get to the new revenue streams that are emerging under these value-based models. That's one of the advantages of coordination and integration. So that's coming, and we're getting ahead of some of that. Contract negotiation, because you're all going to the same person and you're not divide and conquer, you're going jointly. We'll also have some advantages there.
And you just took over Pullman Family Medicine as of April.
Correct.
So how do those competing practices recruit?
So,
Hospitals between?
well, I'm not sure I understand your
They
question.
still recruit separately.
No, we,
Or a hospital recruits a general physician, and that person determines
Okay,
whether they're going to
I see.
Pullman Family Medicine or Palouse Plan.
so I see your question now. So the question is today, Pullman Family Medicine may have an opening. How do they recruit? Is that how's the hospital involvement with that compared to like Palouse Medical Group? Today, we're working closely with Pullman Family Medicine, identifying what the needs are of the community, what type of provider should be there. We work with them jointly. Palouse Medical Group, because they're independent, are out doing their thing. They're trying to recruit in. There's still a competitive model there, although the nice thing is, in our market, I'll tell you today, we work closely with them and have a lot of communication. So thankfully enough, it isn't, you know, eat what one can and kill what you know what. It's you know, whatever I do for me is just my thing, and it's that tragedy of the commons, which we're all going to fish out of the same pond. The more fish I make or catch, the better off I am until we're all out of fish. That doesn't happen today. We do coordinate. So there is some communication, which is nice in our market. It's not a streamline, though, because we don't have that involvement. Yes, sir.
When you talk about coordination, do you see changes in the hospitals? For example, with all of the hospitals in this area, that some of them might end up closing?
That's a great question. So the question is, in this area, will all hospitals exist long term?
Right.
Will some in danger of closing, or is there better models? You know, I would not, I couldn't professionally tell you that all will exist and should exist. There's a lot of duplication of services.
That's right.
And I lived the corridor run for 3 years. It doesn't make sense to have 3 MRIs in a basically 20-mile radius when they're almost $2 million each. Now, you still may need 2 because of volume, but it should be volume driven. I do eventually believe for this area where there has to be coordination of that. You could have a very effective inpatient care unit, and they focus on that, and they do it very well. And still in communities, you know, I'm pointing outside because I think Pullman ought to be central, because they are. They're the middle. And then outside that, you could have outpatient surgery centers or support or urgent care centers, et cetera, but you work collectively. I believe long-term that's where it'll get to. I think until reimbursement dictates that, it won't change. And under a critical access model, because we get paid our costs, what advantages is there to do that? So today we have a fake glass bottom. You know, there's not a lot of incentive to control costs. There's some, there's not a lot. But if that model went away, problem is could you react quick enough? I think that some of that's happening. I mean, we are partners in the general surgeon practices, the specialty practices, medication oncology coming on board. That will be collective. More and more that communication is happening. I think that'll evolve long term. How long? I have no idea. I realize at some point if that happens, and I think that ultimately it needs to. I don't know if you need.
That was going on in Reagan's time when they had, you know, if you wanted a MRI and Gritman wanted one, there was a committee that
Yep.
determined whether you ought to have one because of the population and the size.
Yep.
And that went away.
Yep. I think eventually it'll come back to some of that. I do believe that'll drive it.
Some of us remember there was a vet school that also had a CAT scan at one time, the patients went through a decision by the hospital board again.
Yeah, that was my love of working for 2 facilities. That was awesome. By the way, it is a little after 7. I do want to be respectful of your time. I have nowhere to go. I will stick around if there are other questions, but I appreciate the fact that you all came out. Thank you.
Thank you, Steve.
Yeah, Ruben, thank you very much.